part of that safety net. Before Dr. Engebretsen speaks, I'd just like to acknowledge that we've been joined by a few other legislators. Senator Pam Yocum, the new president of the Iowa Senate, is here. Mary Gaskell, Beth Westman-Cushell from the House, also Representative Gaskell's from the House, and Representative Lisa Heddens is to my left, to your right, and Representative Kurt Hansen is here. So thank you, all of you, for joining us. Dr. Engebretsen is at the podium, and Geoffrey Lauer is on deck.
Thank you, Senator. I'm Beny Engebretsen, the Medical Director of Primary Health Care, which is the federally qualified health center here in Des Moines. We serve a largely uninsured population. Of our 25,000 users, roughly half are uninsured, and of the 100,000 visits that we see each year, roughly half of those are for uninsured. I'm not going to spend any time on access because as I sort of looked around the room and listened to the first speakers, I think there's probably pretty much consensus that access needs to be expanded, whether it's through Medicaid expansion or whether it's through the exchanges. And I'm going to jump down to the hard part, which is actually transforming the system of care. And I think it's been best articulated in the triple aim, which probably most of you are familiar with, but that's improving patient experience of care, which includes quality and satisfaction, improving the health of populations, not just individual patients, which is what healthcare is basically used to doing. And then, of course, the hoped for outcome is that the cost of care will be reduced. The reality is that these are very glib terms, but they are very, very difficult to implement. So some of the bits and pieces of things that are happening now that need to continue, one of them is the medical home experiment that the Iowa Cares program has been undertaking. Granted, it's not the best program in the world. There's lots of gaps in the program, but the idea of making a medical home for these vulnerable populations is very key to this transformation. Along with that, and sort of parallel to that, IME has recently implemented the 2703 Health Home program. Again, this is a pilot program. It's started in July. Lots of challenges. We're learning tons of things as we go in collaboration with IME. These are the kinds of experiments that need to continue. And finally, sort of, again, parallel to all of this is the development of the ACOs. The ACOs are one of the vehicles that probably are instrumental in making the transformation happen. And part of that transformation actually is a transformation of the payment system, because right now, today, we basically get paid for providing visits. What we need to really be paid for is providing quality of services and an improved patient experience. I'm going to beat my 3 minutes.
Thank you, Barry. Barry got me involved in healthcare when he hired me as a consultant. He believed me when I said I knew something about it. I learned a little bit. I learned all I knew from it after I spent a year with him. So Barry and the primary care system and the FQHCs are important to the entire system. Thank you, Barry. Geoffrey is at the podium, and Dr. David Carlysle from the Family Physicians is on deck.
Thank you. My name is Geoffrey Lauer. I serve as Executive Director of the Brain Injury Alliance of Iowa and also as Chair of Iowa's Olmsted Consumer Task Force. The Brain Injury Alliance of Iowa serves and represents the more than 95,000 Iowans with long-term disability from brain injury who live in Iowa. Thank you, Senators and Representatives, for your support of this and also for attending today. As you're aware, the Patient Protection and Affordable Care Act lists 10 benefit categories that must be covered as essential in 2014 by new individual and small group plans. It's yet unclear whether Iowa is going to form its own or connect with a hybrid or other group, but I'm here today to emphasize the need for Iowa to establish an essential health benefit package that appropriately covers rehabilitative and habilitative services and devices consistent with the intent of the Affordable Care Act, guidance by DHHS, as well as the principles of the Supreme Court Olmsted decision. Iowa has the opportunity to greatly enhance healthcare access for individuals with disabilities and chronic conditions by establishing a benefits package that adequately and appropriately covers healthcare benefits without discriminating against individuals based on health or disability status. The benefit design that Iowa ends up with must be measured, amongst other things, against the non-discrimination protections of the ACA, which prohibit discrimination in benefit design based on disability status and mandate that benefit coverage is appropriately balanced among the categories of covered benefits. For many people with disabilities and chronic conditions, rehabilitative and habilitative services and devices are equivalent to the provision of antibiotics to a person with an infection. Both are essential medical interventions. Thus, this benefit category is an integral component of healthcare, especially for persons with disabilities and chronic conditions. With respect to people with such conditions, rehabilitative and habilitative services and devices speed recovery by achieving better outcomes in enhancing the ability to go back home after illness, improve long-term functional and health status, and improve the likelihood of independent living, reduce the likelihood of relapse and rehospitalization, and facilitate return to work in many circumstances. And for example, necessary rehabilitative and habilitative services enable people with a traumatic brain injury to improve cognition and functioning through appropriate therapies and assistive devices. They enable persons with spinal cord injuries to recover and regain functionality. They enable persons born with congenital conditions or developmental disabilities to acquire skills and abilities through habilitation therapies and assistive devices. It also includes in this the term habilitation, ongoing medically necessary therapies provided to individuals with developmental disabilities and similar conditions that need habilitation therapies to achieve functions and skills never before acquired. These skills acquired through habilitation often serve as important developmental building blocks that lead to significant gains in functioning during their lifespan and also decreasing long-term dependency costs. So Iowa should ensure that plans are not arbitrarily restricting restricting certain essential benefits or covering them in a manner that's not balanced across the categories of covered benefits. This may be typical with rehabilitative services and devices that are disproportionately used by a specific population. For example, a restrictive limitation on the number of covered rehab therapies for a joint replacement patient will be totally inadequate for a person who sustained a moderate or severe traumatic brain injury. They just don't line up. Finally, the comment is it's critical that a broad range of constituents be at the table when planning this kind of decision making and when this takes place regarding the essential benefits under the ACA in Iowa. And this must include Iowans with disabilities, with mental health conditions, their family members, and advocates. Thank you.
Thank you, Jeff. Sure. Dr. Carlysle, and then Wendy Sontag from the Leukemia Society is on deck. Thank you, David, for coming. Just acknowledge that Dr. Carlysle was the chair of our last healthcare commission and has an extraordinary amount of interest and background and history for healthcare reform. Thank you for coming.
Thank you very much for having this session, and thanks everybody involved. Thank everyone involved who was who led it to come to fruition. You know, I'm a family physician and hospice physician in Ames. As a member of the American Academy of Family Physicians and an Iowa Academy of Family Physicians, I followed for years their decades pursuit of universal health care coverage, and in that pursuit I've been involved in many public policy access. Excuse me. There you go. Sorry. I'm a family physician and in Ames and a hospice physician, and I've been pursuing through the efforts of the Iowa Academy of Family Physicians, American Academy of Family Physicians, universal health care coverage, and worn many hats. And I'm going to talk about a couple of those hats today in talking about health care coverage. The Affordable Care Act takes place in the most major sense in 2014. This legislative session, 2013, you will make pivotal decisions regarding how this is going to play out and how how far we go down the road to obtaining universal health care coverage, and I'd like to talk about a couple of those. I divide the Affordable Care Act into concerns about access, the care, and also the affordability. I'm going to kind of focus my remarks on 4 parts of that. Regarding access, I put on my hat as the former chair of the Legislative Health Care Coverage Commission for 2 years. In 2009, 2010, we took on the task of looking at exchanges. We had work groups in each of those years. We came up with good products, and I would ask the legislature to go back and look at those 2 years worth of notes and recommendations. Under the able leadership or able help of Ann Kinsel, we came out with some great recommendations for exchanges. You know, exchanges are the supermarket where you go to buy a loaf of bread, which is your insurance policy. It's also where you learn whether you qualify for Medicaid or some other program, and it's also where you will be able to receive federal subsidies. So it is critical we get it right, and I think we haven't been able to live up to that promise as far as getting it organized as well up till now, and I hope we can do it now because we need to. The second part of access is Medicaid expansion. You know, I'll put on another hat. I'm a member of the Medical Home Advisory and Chronic Care Advisory Committees that are now joined. We had our meeting last week and we voted unanimously to support Medicaid expansion. It makes total sense to provide care. You cannot have universal access coverage without that. 2 other parts real quick regarding costs is the idea of the co-ops. You know, I was a member of the National Advisory Board for Healthcare Co-ops. We heard from Group Health in Seattle. We heard from Health Partners in Minneapolis. You know, they have co-ops that have been unbelievably important, and now we're going to have one in Iowa, Nebraska called Co-Opportunity Health. And finally, I'll share my last hat as a physician. I really support what was mentioned by Ms. Kelly regarding the rural physician provider repayment program. We need to continue to work with that at the legislative level. I'm very excited about the prospects of what you can do this year, and so 2014 we can move forward. Thank you very much.
Thank you, Dr. Lauer. Ms. Sontag, and then Charlie Wishman from AFL-CIO is on deck.
Good morning. I'm Wendy Sontag. I'm the Patient Services Manager for the Leukemia Lymphoma Society, the Iowa chapter. The mission of the Leukemia Lymphoma Society, or LLS, is to cure leukemia, lymphoma, Hodgkin's disease, and myeloma, and to improve the quality of life for patients and their families. LLS is the world's largest voluntary health agency dedicated to blood cancer. Today, we'd like to focus our comments on our top priority for 2013, ensuring that cancer patients have access to comprehensive care as a part of the essential health care benefits package. Regardless of how the state chooses to participate in federal health care reform, it should preserve those benefits that Iowa has identified as critical to cancer patients. LLS supports implementation of the EHB packages that include the following 3 comprehensive cancer care components. Number 1, to ensure that cancer patients have timely access to the full range of prescription drugs necessary for evidence-based anti-cancer regimens, including drugs and biologicals, whether administered incident to physician services or self-administered, drugs and biologicals for off-label uses according to the evidence-based standards utilized in the Medicare program, and affordable access to procedures standard to the treatment of blood cancers, including bone marrow and cord blood transplants and radiation therapy. A second necessary component would be pharmacy benefits that include the following: prescription drug benefits with full coverage of the 6 protected classes, inclusion of multiple drugs in a range of therapeutic categories as defined in the Medicare Part D program, and a patient appeals process for patients taking a specific drug not on the new plan's formulary. Also, individual comprehensive cancer care planning, including survivorship planning that is communicated by healthcare professionals both orally and in written form. Also, formulary standards that include inclusion of multiple drugs in a range of therapeutic categories and comprehensive coverage for therapies needed by the most vulnerable patients. independent pharmacy and therapeutic, or P&T, committees that review the drugs included on those formularies, as well as the utilization management requirements for such drugs, and consider newly approved treatments and indications for inclusion in formularies within certain timeframes, such as those required under Part D. And also a mechanism for incorporating new therapeutic categories or classes in order to protect patients' access to innovative therapies as they become available. A final component would be explicit safeguards needed to ensure that the policies governing out-of-pocket costs for cancer patients are no more burdensome for oral cancer drugs than intravenous cancer drugs. Iowa established this standard in 2009 in Senate File 478, authorizing oral chemotherapy treatment to be covered by insurance in the same manner as standard chemotherapy. We appreciate the opportunity to comment today on these critical issues of need for oncology patients in Iowa, and will participate actively in the process as you further develop the framework for any healthcare exchange. Thank you.
Thank you very much. Charlie Wishman, and then Greg Botenhammer's on deck. And if I could ask the speakers to adjust the mic so that the long mic is in front of you so that the people in the back can adequately hear. Thank you.
Thanks, Rusty. Senators Hatch, McCoy, Reagan, other legislators who are here, thank you for holding this hearing on this important topic that touches everyone in one way or another. My name is Charlie Wishman. I'm the Secretary-Treasurer of the Iowa Federation of Labor, AF-CIO. So first and foremost, the Iowa Federation of Labor and our affiliates believe that Chapter 20 allows for negotiations on the issue of health care coverage for public employees covered by a collective bargaining agreement, and there are no need for any changes to that. It is not appropriate for a legislative body to inject itself into the collective bargaining process, and Chapter 20 has served both employers and employees well for decades now, and legislative changes, especially during contract negotiation process currently going on with state workers, is a very bad idea. Secondly, Iowa needs to develop a consumer-friendly health insurance exchange that will work for Iowans who have no health care coverage. Whether or not it takes the form of a state, federal, or partnership exchange, it should be transparent, affordable for consumers, easy to use, seamless with existing programs, and with an emphasis on quality outcomes. If the Iowa House and Senate are unable to reach an agreement with each other or with the governor on the details of a state-based exchange that is consumer-friendly, we would urge you to allow the federal government to set up an exchange. No agreement on a state or partnership exchange is better than a bad one. Lastly, the Affordable Care Act. For the Affordable Care Act to be properly implemented in Iowa, our state needs to expand Medicaid as outlined in the ACA. It makes no sense for Iowa to reject this expansion. As it has been pointed out by some today, if an expansion is done right and includes many of those on Iowa Cares, an expansion could actually save Iowa money. An expansion of Medicaid would result in uninsured people having health coverage that are lacking it now, and fewer of them will seek care in our emergency rooms. Furthermore, not only would a partial expansion that is below 133% of the federal poverty guidelines undermine the whole point of the ACA to provide coverage to the uninsured, it also appears that it may be illegal, according to many health law advocates. So thank you for taking the time to hear our views on healthcare. While some of these issues may not affect union members directly or at this time, it is important for everyone to know that organized labor is committed to working with all interested parties towards improving our healthcare system for everyone. Thank you.